Just want to say thank you and good morning, everyone, and welcome to today's webinar, Behind the Scenes in the IVF Lab, How Technology Builds Families. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to the email you RSVP'd with by Harvard around July or August. Additionally, we encourage you to submit questions to Dr. Sakkas and Dr. Rossi using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. Now, without further ado, I would like to introduce today's speakers. Dr. Denny Sakkas is the Chief Scientific Officer at Boston IVF, where he actively cultivates new technologies that improve embryo development in our lab. Dr. Denny Sakkas received his undergraduate training at the University of Melbourne, Australia, and received his Doctorate of Philosophy at Monash University, Melbourne, Australia. Dr. Sakkas earned his PhD at one of the leading reproductive research units in the world. He has extensive experience in clinical IVF and reproductive research. He is internationally recognized, having organized numerous conferences and workshops on reproduction-related topics, and is frequently invited to speak at major conferences worldwide. He has published more than 200 peer-reviewed manuscripts and chapters in the field of fertilization, early embryo development, and male infertility. Dr. Brooke Rossi is a board-certified reproductive endocrinologist at Ohio Reproductive Medicine. Dr. Rossi is a graduate of the University of Pittsburgh School of Medicine and completed her residency in obstetrics and gynecology at the University of Rochester. Her subspecialty fellowship in REI was completed at Brigham and Women's Hospital and Harvard Medical School. Her clinical interests include recurrent pregnancy loss, polycystic ovarian syndrome, and minimally invasive surgery. She also has a special research interest in lifestyle factors, fertility, and in vitro fertilization. She's been published in Obstetrics and Gynecology, Fertility and Sterility in the Journal of Clinical Endocrinology and Metabolism. Dr. Rossi is an adjunct assistant professor in the Department of Obstetrics and Gynecology at The Ohio State University. She is a member of the American Society for Reproductive Medicine and American College of Obstetrics and Gynecologists. All right, we're ready to get started. I'm going to pass it over to Dr. Rossi. Thank you.
Hi, everybody. Thank you so much for joining us today. We're going to go ahead and get started with the presentation now. Can you go ahead to the next slide?
Yeah, sorry.
Okay. So what we're discussing today are 3 different technologies that are used within an in vitro fertilization cycle. So I just wanted to spend the first few minutes reminding us all about the details of an in vitro fertilization cycle. The first part of an IVF cycle is the controlled ovarian hyperstimulation. So an IVF cycle itself, from the time that the patient starts taking medication until the time that she finds out if she's pregnant, is about 1 month. And the first, I would say, 8 to 12 days are the controlled ovarian hyperstimulation, in which the woman takes injections of follicle stimulating hormone or LH hormone and several other hormonal injections to try to get her to make several eggs all at once. So you can see in the first picture, this is what the ovaries may look like at the beginning of the IVF cycle when they're nice and quiet. And then you can see on the right side, many ovarian follicles that have grown, and this may have taken place over the course of approximately 10 days. Once the ovaries look to be in this way, when the follicles are a good size, we think that we will be able to retrieve mature eggs. So then the patient undergoes an egg retrieval. This is just a brief diagram of the egg retrieval. So this is a transvaginal ultrasound guided procedure. The patient is usually asleep for this procedure, or at least gets some amount of anesthesia. When the ovaries are enlarged and full of the follicles, they do kind of settle lower into the pelvis. And they can be accessed by using a transvaginal ultrasound probe and using a kind of long 17-gauge needle to go along the probe, enter into the vaginal, traverse the vaginal wall, enter into the ovary. We drain the ovarian follicles. The fluid goes to the embryologist and they look for the egg. And so we do that on both follicles, or both ovaries rather. The patient may have an embryo transfer approximately 5 days later, or she may have an embryo transfer at some time in the future, whether it be months or years from the time she has the eggs retrieved. And this procedure is very simple. It requires no anesthesia. Essentially what happens is the embryo is loaded into a catheter by the embryologist, and then the physician uses a flexible catheter to go through the cervix and then places the embryo into the upper uterus. The first procedure that we're going to talk about that has been definitely a milestone in our field is how we fertilize the eggs during an IVF cycle. There are two ways to fertilize the eggs during an in vitro fertilization cycle. The first way is called conventional insemination. And so what that means is we will get the eggs from the patient, and the embryologist simply puts the eggs in a petri dish and may put thousands of sperm around the egg. And essentially what happens is over the course of several hours, the sperm basically enter through the zona pellucida, or the surrounding of the egg itself. The other option is to do something called intracytoplasmic sperm injection, or we call that ICSI. And in that situation, the embryologist will take the egg after it's been retrieved from the patient. They remove some of the cells from around the egg, and then they use a very small needle to actually place the sperm directly into the cytoplasm of the egg. This sperm that is used for ICSI can be either from an ejaculate sample, or if the man has no sperm available on ejaculate sample, can be surgically retrieved from the patient or from the man. And the sperm that's used for ICSI can be either fresh or frozen. Indications for ICSI include very poor quality sperm, either low numbers of sperm or sperm that are not moving well or have poor motility. Azoospermia, or no sperm found in the ejaculate, is another indication for ICSI. So this may be simply because maybe a man's had a vasectomy and the sperm can be aspirated and then used for ICSI, or maybe this is a man that has azoospermia and ejaculate sample but can actually have a testicular removal of the sperm. We also think that there can be changes in the structure of the egg when those eggs have been frozen. And so a third indication for ICSI would be fertilizing eggs after they have been frozen. When eggs have been frozen, the outer shell of the egg, called the zona pellucida, may change such that it may be hard for sperm to fertilize the egg with conventional insemination. Therefore, ICSI is recommended to be used in this scenario. Another reason that we use ICSI may be for preimplantation genetic testing of the embryo. So you can imagine if we're doing conventional insemination, there's a lot of sperm near the egg, that there can be contamination of the genetic material that may be then pulled from that embryo. So when we're doing specific genetic testing, we actually only want the DNA from one egg and one sperm, so that can be an indication for ICSI. We'll talk more about preimplantation genetic testing in just a few minutes. And finally, we will often use ICSI in an IVF cycle if the patient has done a prior cycle, maybe where they've had less than expected number of eggs fertilized, or if there's been a failed fertilization, which is when no eggs have been fertilized. And this happens on rare occasion, that a couple will come to do an IVF cycle and they may have the semen analysis may look totally normal, but then lo and behold, we try to fertilize the eggs with conventional insemination and there may be no fertilization. And so this would be an indication for their second cycle to do ICSI. It is also, so that was a very comprehensive list of the reasons to do ICSI. But we also have to be thoughtful about, limiting use of ICSI and making sure that we're using it only when we know that there is a benefit. And so there may not be a clear benefit to use ICSI in couples who have unexplained infertility. And again, unexplained infertility is the infertility that a couple may experience when they, when the woman seems to be ovulating, has a normal hormonal panel, when her fallopian tubes are open, and when the semen analysis is normal. It's also not indicated to do ICSI in a woman who has advanced maternal age, or has poor quality eggs, or may have few eggs developed from an IVF cycle. And we also want to be thoughtful about not using IVF just routinely in all IVF patients. There does appear, and the reason why we want to be thoughtful about using ICSI is that there could be a slightly greater risk of birth defects when ICSI is used in couples who don't have male factor. We do see that there is a slightly greater risk of birth defects in babies born from men who are doing ICSI who have severe male factor. And in that scenario, I think, ICSI is very helpful because it may be that without ICSI, IVF would not be successful for that couple. But we just want to be thoughtful about making sure that we're using it in an appropriate way because of the increased risk, even if there is no male factor seen. It's also important to understand that, especially for our patients with azoospermia. So let's take our, if we have a male patient who has cystic fibrosis. Often men with cystic fibrosis have something called congenital bilateral absence of the vas deferens, and that may cause them to have azoospermia. So their sperm can be retrieved and they can do IVF and they can have families of children. Of course, that man could also pass on cystic fibrosis. So you just want to make sure that if you ever had a patient who had something like cystic fibrosis or Y microdeletion, or maybe even something like Klinefelter's, that couple is having genetic counseling performed so they understand the risk of potentially passing on the disease as well. And for our patients who are paying out of pocket for IVF, or even potentially with some insurance coverage, there can be an extra cost to ICSI of at least several $1,000s.
Thanks, Dr. Rossi. So I was just going to show people how we actually perform ICSI, and ICSI's, as Dr. Rossi said, is an incredibly powerful technique because about 30% of our couples have a male factor component. So when the first IVF pregnancy was achieved in 1978, it was obviously for a much simpler scenario of infertility, a patient with blocked fallopian tubes. But ICSI, when it was first performed in 1992, actually opened basically the infertility treatment to this 30% of patients. And it's become such a successful technique that we actually use it in many more patients. And if you look at the data overall, about 60%, 70% of cycles worldwide are actually using ICSI. So there is an argument that it's actually overused. But you'll see in this video that it's a very interesting technique. So here, this is a small pipette. It's about 5 to 6 microns in width. The sperm is actually taken up and is actually brought by the injection pipette very close to the egg, and then it actually is brought in and penetrates the egg. And you'll see here the process actually involves breaking the cytoplasm. So you'll see the cytoplasm of the egg just pop there and actually be injected in to the egg. So you'll see the sperm actually come down now just from the right-hand side into this pipette. The pipette on the left-hand side is what we call a holding pipette. This is holding the egg in place, and you can see the egg now has actually the sperm placed inside it. You can see here the sperm just right in the center. This furrow is where the sperm actually, or the pipette, has entered into the egg. We're incredibly lucky in terms of there are certain things that go on in human IVF that actually favor us extremely. And one of the things is that this egg, you can see here, this is called the zona pellucida. It's like a shell that protects the egg. This is the actual membrane of the egg. And what's really interesting, this egg membrane at the stage that we actually do fertilization is incredibly liquidy. It's basically like water in many ways, not exactly like water, but it actually has incredible capabilities of actually allowing that pipette to come in. And if you actually look at this egg 20 minutes later, you would not even recognize where this hole was actually placed into the egg. So there's actually, it's very, very rare now that an egg is actually damaged. So this process is extremely powerful in terms of allowing us to treat male factor infertility. So once you've actually performed this technique, the eggs are taken away. They're actually cleaned and put into our special growth media, culture media, and then actually the following day we actually check for fertilization. And I'll show some movies a bit later on about how fertilization is checked. But one of the things I actually wanted to mention, so one of the things that we basically skip, if you want, in terms of fertilization is that we actually act in terms of the sperm selectors, if you want. So when we're doing an IVF conventional insemination, as Dr. Rossi mentioned, we take 100,000 sperm, we put them around the eggs, and we basically let the sperm work out themselves how they actually get into the egg and fertilize the egg. So there is a sperm selection in process. But one of the things we've been working on is that for ICSI, it's basically us just looking at the sperm down a microscope. It's a bit of a, you know, which one's moving the best and which one looks fairly normal, but that's a pretty abstract way of selecting the sperm compared to what evolution has put in place. So there are techniques that we use to try to pick the best sperm, and this is one technique that's it's actually mimicking what is around the egg, and it actually allows good sperm to actually bind them. So if you look here, some sperm are actually stuck on this like little line, if you want. Others are just swimming around as if they, you know, they've got nothing else to do, basically. So what we can do is actually we can come down with the pipette that we choose the sperm with, and actually choose the sperm that actually have bound to this substrate that mimics what the egg is actually doing. So this is a technology that we're looking at, or we use clinically actually for many cases, where we actually try to enhance the sperm selection that we do. And this is actually now going into more of the future. This is a technique that we're actually using artificial intelligence and video recognition software. So similar to what actually, when you look at your iPhone or your phone and it recognizes that's who you are, you can use similar technologies that actually look for particular patterns in a sperm and tell us this is a sperm more likely to fertilize compared to one that is not able to fertilize. And this technology we're using, we're testing now, where in basically a split second, the technology or the software can recognize which are good sperm and which are bad sperm. And actually what it does, it lights up the sperm so it allows us to come in and pick the sperm. So this is an amazing technology that we're actually testing now in our own laboratories to try to enhance the chance of selecting the best sperm, which then translates to better fertilization rates and hopefully better embryo rates and actually better pregnancy rates. So once we've done all that, what do we look for? So what do we look for? So if I did an ICSI, for example, at this time today, tomorrow morning, hopefully this is what I'm going to see in front of me down the microscope. So this is you saw the egg being injected before, but this egg here actually is fertilized. And the way we tell this is actually you can see like two small pools within the egg. One represents the male genome and the other represents the female genome. So once we actually look at these embryos, once we do ICSI, the following day, about 16 to 18 hours later, we then start checking for fertilization, and that's how we know that the case is progressing and we'll have fertilization. Brooke, I'll pass it on to you now.
I love watching these pictures. You know, we spend all day in the office. We don't get to go in the lab. So I love whenever I see pictures from the lab. So thank you, Dr. Sakkas. All right. So the next topic we wanted to discuss today is a topic that a lot of patients have questions on, and is also, I would say, one of the major advancements in our field, you know, in the last several decades, and that is pre-implantation genetic testing. There are 3 different types of pre-implantation genetic testing, and you know, the names have changed over the years. So right now we are talking about 3 different types of genetic testing. One is called PGTA, and it's A because that stands for aneuploidy. And this is probably the most common type of PGT that we do. This is looking only for conditions that are associated with an abnormal chromosome number or an aneuploid embryo. So things that you would potentially look at would be a trisomy 21, a trisomy 13, monosomy X. So again, just conditions that affect chromosome number. This is also the most common technology that we use for women who are maybe advanced maternal age. You know, as we know, the risk of aneuploidy goes up as they get older. So this is the testing that those women would primarily utilize. The second type of testing is called PGT-M. and that is looking for a monogenetic disease. These are things like cystic fibrosis, spinal muscular atrophy, and these patients come to us primarily in one of two ways. Sometimes a couple has just done routine carrier screening and they find out that they both carry hereditary diseases and they want to try to lessen their chance of having a child that's affected or a carrier. But I would say the other very common way that these patients present to us is, a woman will come in and say, I didn't know I carried this, my partner and I carried this disease, and we just had a child that was affected, or we had a pregnancy that was significantly affected, and we don't want that to happen again. In that scenario, the patient and her partner have a probe made from their blood that helps look for their specific gene that they have that can affect the embryo. And these can be autosomal recessive diseases, autosomal dominant diseases, or sometimes X-linked diseases. So just an example, I have a patient right now whose child was affected by a very small microdeletion on the X chromosome. And it's so small that the genetics companies think that we can't make a probe for it. But because it's X-linked recessive, she and her partner have decided that they will just have a girl. They're actually looking just for gender, to have a girl, because they don't, it would not be expected that the girls would be affected by the disease. And then finally, there's PGT-SR, and that is what we use for patients who may have a balanced translocation. So sometimes in our evaluation for infertility or recurrent pregnancy loss, we will find that either the patient or her partner has a balanced translocation. Again, these balanced translocations can be associated with infertility, but more commonly in recurrent pregnancy loss. And so we can have the embryo undergo testing to make sure that the embryo is balanced or has the right amount of genetic material to continue as a pregnancy. Some of the indications for PGTA, first primarily would be patients who are at risk for having a child with a specific medical condition. And again, that would be our patients proceeding with PGT-M. Avoiding having a sex-linked genetic condition. Examples of that would be X-linked diseases, something like Fragile X could be another reason why people may choose to do this. And something that's more uncommon, but is definitely a possibility, and I've seen in practice, has been the effort to try to have a child that is an HLA match for a sibling who is already, may need a stem cell therapy. Avoiding pregnancy loss in a patient or a partner who has a balanced translocation. And then finally, if we had a patient who needed just to have a single embryo transfer, that would be a reason to do PGTA. So let's say we had a patient maybe who was older, and her option would either be to have multiple embryos transferred to try to compensate for the impact of age, or to have her embryos tested and just have one transferred. That would be a good indication for her to do PGTA to make sure that the embryo she was transferring was euploid and not aneuploid. To complete PGT, the embryos the embryos are created with a pretty standard IVF cycle. So patients who are doing PGTA, whether they're doing it as in conjunction for infertility treatment or whether they're doing it for PGTM, essentially undergo the same process. However, instead of transferring the embryos are grown to the blastocyst stage, which may either occur at day 5, 6, or 7 after the egg retrieval. And then the embryo is biopsied, and we'll let Dr. Sakkas talk a little bit about that. Those cells are then analyzed for whatever genetic issue they're concerned about. So again, either looking for a specific disease or just making sure that the embryo has the right number of chromosomes. And then the embryo transfer may happen in the future. It could be 1 month later, it could be 3 years later. And the companies that do the testing for us and the genetic counselors at the companies that do the actual testing of the embryo cells still counsel patients that they should have routine prenatal screening. So those patients may still undergo a CVS, they may still undergo amniocentesis. So doing PGT does not give them a reason to not do any further testing.
So Brooke gave us some reasons of why to do PGT or aneuploidy testing. So I'm just going to show you some data here. This is from our own laboratory, why it really helps in certain patients and why we sometimes do it less in other patients. So on the left-hand side here is a graph. The pink line basically is the rate of abnormal embryos a patient has as a percentage of how many embryos they have. So, and the bottom line here is actually a line of increasing age. So younger patients here and older patients on the right-hand side. So if you look at, let's look at a 20 to 30-year-old, you can see on average about 30%, 25 to 30% of the blastocysts that we test will be abnormal. This may sound like a striking number, but that's the reality of abnormal embryos in a patient, regardless if they're doing IVF or not. An interesting quirk here is very, very young patients actually have a slight increase in aneuploidy rates or abnormal embryos, and there are biological reasons why that occurs. But as you actually get into the 30s, which is the sort of majority of a lot of our patients, and up into the 37, you can see there starts to be a slight increase in the level of abnormal embryos that a patient will experience in an IVF cycle. And then once you get over 38, you start seeing that there's a dramatic rise in the level of aneuploid embryos. So, the sad part of this is that you can't fight the biology that actually a woman doing an IVF cycle in her late or her early 40s will unfortunately have a high rate of abnormally chromosomal embryos. And that's just the reality of the biology. But the good part is that if we can find that euploid embryo, even though there's fewer of them compared to a 30-year-old, the pregnancy rates are actually exactly the same. So once we have that nice euploid embryo, even in a 40-year-old, the embryo actually behaves as if it was a 30-year-old, an embryo from a 30-year-old. So this is the power of PGT, that actually once you find that aneuploid embryo, the patient has an excellent chance of getting pregnant. Now, the type of patient that it also helps with, obviously, is the patient who has recurrent pregnancy loss because of aneuploidy, for exactly the same reason, that you're actually pre-assessing those embryos so they're euploid rather than aneuploid. So there's a strong indication for using testing for aneuploidy in older patients in particular. The patients we really are less sure of are the very young patients, or where what you call an older woman. So do we treat patients more in the 35 and over group or 38-year-old group? And I think one of the things, as Dr. Rossi mentioned, is that the two things that PGT does allow us to do more confidently is, one, transfer that euploid embryo, but also to actually transfer a single embryo, which is actually recommended in most cases, because we know that even a twin pregnancy, and not to mention triplet pregnancies, are very dangerous both for the infant and for the mother. So how do we do this technique? So we obviously grow embryos up to day 5, day 6, or day 7. And what we want in front of us is an embryo that is at the stage of blastocyst development. And a blastocyst has 3 characteristics. It has fluid in the center. So if you picture it like a spherical ball, it has fluid in the center. At one pole, it has what's called the inner cell mass. So the inner cell mass is actually aligned along the wall, but actually is a group of cells that actually will go on to form the fetus or the baby. And then thirdly, you have cells that are actually like the outside of a soccer ball, if you want, which are called the trophectoderm. And those trophectoderm cells are the ones that actually will go on to form the placenta. And what we do is we don't touch the inner cell mass cells, obviously, because they're cells that we don't want to play around with. But what we actually do when we're taking a genetic test is actually go to these trophectoderm cells and take about 5 to 7 of those. And a blastocyst could have anywhere between 50 cells and 150 cells when we're actually biopsying it. But we're able to take this small biopsy from these trophectoderm cells, normally at the opposite end of the embryo, so we're not near the inner cell mass, and hopefully that's representative of what the embryo's chromosomal status is. So here you have, again, similar to what I showed you before, this is called a holding pipette. It's holding the blastocyst in place. This is an area of trophectoderm that we will actually go to and actually pull off some of it. And then basically we take this part for analysis, and the remainder of the embryo is then frozen, as Dr. Rossi said, that for later analysis. So you'll see here this video. So this is called the biopsy pipette. This little red dot is actually a laser that actually helps us take away the piece of cell. So this looks very traumatic, but it's actually not that traumatic for the embryo. So you can see here, if I stop this, you've got now hold of 5 to 7 cells. And what will happen now is with the laser, we'll actually we'll look at the junctions of the cells and actually try to pull them apart so we can actually take the biopsy. So if I continue this, you can see now the laser is actually, is actually shooting at the area where we want to remove the cells. So you can see here, it's going to basically tear the cells along this like zip line, if you want, here. And you'll see the cells taken into the pipette. You can see here now, this is tearing apart. The embryo is on the left-hand side and the biopsy we want is on the right-hand side, and that will go into the pipette. And the aim then is to actually take those cells that we have for the biopsy, we separate those, send them for analysis, and the embryo is actually stored frozen until we have the full analysis of the embryo. So you'll see now that piece of cell tear off. You can see it there. You can see here the embryo remains intact. It doesn't disintegrate or collapse. And again, as I mentioned with the ICSI technology, we're actually very lucky, you know, that the embryos have you know, some flexibility and allow us to do these techniques. So this actual embryo is then taken. It's frozen by a technique we'll talk a little bit about later called vitrification. The vitrification process, or the freezing technologies we use, are actually incredibly successful. We basically expect virtually every embryo we freeze to come out in the same state when we thaw it. And the pregnancy rates are actually incredibly high using these frozen embryos, probably even better than fresh. And there's clinical reasons why that's the case. So once we have this embryo, we then also have this piece of tissue that we biopsied. So that piece of biopsied cells, the 5 to 7 cells, is taken. It's put in a small tube, sent for analysis. And the key component is that we know exactly which piece of cells belongs to which embryo. We track those, we witness those, all those are documented. So we virtually completely minimize the case of any mistake being in misidentifying the embryo. So then this piece of cells is sent off for analysis. In about 2 weeks, we will get that analysis back, and we know which embryos are actually chromosomally normal and which embryos are actually abnormal. So then we can actually transfer the normal embryo back to the patient. And as I said, regardless of age, whether it's a 30-year-old patient or a 42-year-old patient, if we have a euploid embryo, euploid blastocyst in front of us, we expect that patient to have approximately a 60% live birth rate. So it's an incredibly powerful technique. So this technique, you know, one of the drawbacks, as we see, is that it is actually quite invasive. So we're actually developing techniques that actually give us the same information, but actually will allow us to actually do it without actually taking that biopsy from the cell, from the blastocyst. So we're working on a number of projects, and this is one. These are mouse embryos I'm about to show you, but it's a technology that we're using which actually uses a specialized microscope to look at the metabolism or the health of embryos. Now, you'll see like a fluorescence image coming up here from these embryos, but actually it's actually factors in an embryo, and human embryos do exactly the same, that do what are called autofluorescence. So in our bodies, there are certain things that actually, if you excite them and look at them under a microscope, they actually autofluoresce. So we're not adding anything to look at these embryos. This is all done non-invasively. And you'll see here, these are mouse embryos growing, but we're doing this in a trial in the human. You'll see these are embryos from mouse growing from 1 cell, 2 cell, 4 cell, right through to the blastocyst stage. And you can see these are 2 metabolic signals we're looking at, which give us sort of different types of information. If you look here at this is an 8-cell embryo, you can see how these embryos are very bright and these embryos are not that bright, but actually these signals are telling us about the metabolic health of the embryo, and we're now actually getting information that actually will tell us which of these embryos would actually be more likely to give become a baby versus one that wouldn't. So it's very similar data that we're getting compared to what we're getting from pre-implantation genetic testing.
Great, thank you. The final topic we wanted to discuss today was egg freezing. Go ahead, you can start with the next slide. As you all probably know, there is an impact on fertility and the chance of having a baby as women get older, because women are born with all the eggs they're ever going to have. And in fact, we have the most eggs we're ever going to have, even when we're a fetus. And that oocyte atresia occurs throughout life and then accelerates after, the mid-30s or the age of 37. And as we'll talk about, there are intrinsic factors and sometimes extrinsic factors that may affect ovarian reserve in any one particular patient. So not only do we get less eggs as we get older, but we also get a decrease in the oocyte quality. And what I mean by that is that those eggs are more likely to be aneuploid or be more likely to produce aneuploid embryos or aneuploid pregnancies, which will either A, decrease the chance of getting pregnant, or B, may increase the risk of having a miscarriage, both of which decrease the chance of having a baby. This is a nice table from a New England Journal article talking about different reasons why people may want to freeze eggs. And egg freezing hasn't gone on for decades, but really was deemed by the FDA to be non-experimental in the last 10 years. And so when that happened, people started utilizing egg freezing much more. Some of the reasons that people may choose to freeze eggs may be patients who are at risk for an impact on their fertility because they may have had a recent diagnosis of cancer or have a medical condition which will require them to have chemotherapy or pelvic radiation. Or they may be faced with a surgery on their ovaries, which may also affect their ovarian reserve. I have seen patients who have a history of severe endometriosis and may have had multiple surgeries on their ovaries, and the physician may say, before I do another surgery, I'd like this patient to consider doing egg freezing. And then finally, some of the intrinsic factors can be that, as you know, there can be patients with Turner syndrome, and probably in our scenario would be more like a Turner mosaic patient who would be a candidate for having egg freezing, patients who are premutation carriers of Fragile X syndrome, or maybe even patients with a family history of premature ovarian failure may seek to freeze their eggs while they still have ovarian function. We've also cared for patients who may be carriers of something like BRCA, who are thinking to themselves, I'm not done having my family, but I'm nervous about my risk of cancer. I'd like to freeze eggs and then have my ovaries removed. And then finally, there can be some events that can come up during an IVF cycle, such that if we have a couple where the man has very few sperm, such that the only option is to freeze the excess eggs, or if we have a couple who maybe have religious beliefs such that they only want to make a certain amount of embryos and they may have more eggs than they need, so they may consider freezing those eggs as well. And then finally, what's really picked up, I would say, in the last several years would be the use of, and this has different names that they have it. It can either be called elective egg freezing or societal egg freezing, but basically women saying, I'm not ready to have a child yet, and I would like to freeze my eggs to maintain my fertility and have that fertility I have now, but later on when I go to use the eggs. And we do know that women are delaying childbearing, and this may be a way for them to preserve their fertility. When we have a patient that's interested in freezing eggs, usually we'll see them for a consultation, and we will also try to assess their ovarian reserve so we can try to give them an idea of what their chances are of having a baby from that particular cycle. And there are some very good articles and even some calculators online that we use that, you know, put in sort of how many eggs we think that woman will be able to achieve with an IVF cycle and her age, and help us make a calculation of the chance of having a baby from that group of eggs retrieved from the cycle. When the woman is ready to do the cycle, she may undergo a cycle just like any other patient doing IVF for infertility. So that process of ovarian stimulation and egg retrieval is the same as we discussed at the beginning of the conversation. However, those mature eggs are then cryopreserved or frozen on the day that they are retrieved from her. And then I always want to make sure that patients understand, and they usually do, but I always make a point of telling them that, you know, when they go to use the eggs later on, they need to, it's almost like you're completing the other half of the IVF cycle. So they still need to have those eggs thawed and fertilized and have an embryo created. They can't just, you know, put the eggs in their body and hope for the best. They actually have to complete the IVF cycle. One of the most important parts of the counseling when we're discussing this option with patients is to understand what their chances are of having a baby from the group of eggs. And this is very important in sort of setting realistic expectations for patients. So the most important factors in determining someone's chance of having a baby with frozen eggs is the age of the patient and then how many eggs she has. So in some of the studies, you can see here that if a woman is less than 38 and she can have 15 to 20 eggs retrieved, she may have at least 70 to 80% of having 70 to 80% chance of having a baby from that group of eggs. Now, as women get older, because each of those eggs has a lower potential to be normal and give her a baby, she needs to have more of those eggs. Now, of course, as you get older, your ovarian reserve goes down, so it gets harder to get more eggs from the cycles. So sometimes the only way to get the amount of eggs a woman needs to have the chance that she wants to have in the future is to have her do multiple cycles and retrieve multiple batches of eggs. Now, with this being, you know, often an out-of-pocket procedure, at least a lot of times my patients don't have the ability to do that, and so they do their best. We get as many eggs as we can, and then we kind of regroup afterwards and say, all right, here's your age, how many eggs that you had retrieved, and here's your chances. And sometimes they'll say, that's great, I've done my best, I'm happy with that. Sometimes they'll say, well, I want to try again in the future. And so they've also tried to do studies to understand the best time to do this, right? Like this would not be something probably that should be offered to every 25-year-old woman because she still has years to potentially find a partner and have a family the old-fashioned way. And we also think that this is a harder option for women who are in their early 40s because they need so many eggs to give them a good chance to actually have a baby with those frozen eggs. So some of the studies suggest that sometime in the early to mid 30s would be an ideal time to do this. If you have a woman who's 34, doesn't have a partner, isn't ready to be, you know, a parent, and sort of looks out and says, well, even if I met someone tomorrow, I might not be ready to have a kid for 2 years, and then I know I want to have several of them, that would be a very appropriate person to consider egg freezing. IVF has been around for decades, at least 40 years. Egg freezing has not been around as long. And so we have decades and decades of safety data and outcome data on people born from IVF using fresh eggs, and not as much with frozen eggs. But the studies that we have are very reassuring. So there does not seem to be any increased risk of miscarriage, aneuploid pregnancies or embryos, birth defects from using frozen eggs compared to fresh eggs. The live birth rate seems to be similar to a patient, two age-matched patients doing IVF with fresh eggs versus freezing eggs and using them later, and there does not seem to be any increased risk in pregnancy complications from using frozen eggs. It's important to understand that in many cases, this is an out-of-pocket cost for women, and unfortunately, that's one of, I think, the limiting factors for a lot of our patients. A single cycle of the monitoring visits, the surgery, the anesthesia, the embryology costs may be somewhere around $8,000, and the medications may be several $1,000s more. And then those women have to store the eggs over the course of years. And again, from place to place, that could be somewhere in the ballpark of $500 a year. And sometimes often these patients don't have insurance coverage. So unfortunately, even in scenarios where, you may have two women doing the same job, one of them has infertility and has her IVF covered, and the other one doesn't have infertility, might not have this covered. There are, though, some nice new companies who are offering this to women if they choose to do it. It's not too strenuous. The patients may expect, several visits, but they can usually, work around, have their schedule work around it, and they just need one day off work to do it. It is important that the woman understands she does need one person to drive her home from the procedure because of the anesthesia.
So, thanks, Dr. Rossi. That that sort of gives you an idea of about egg freezing. But how has it changed over the years? Why can we offer it now, whereas many years ago we really couldn't offer it? And one of the main reasons is that we now have a technique that we use that I mentioned before in terms of embryo freezing, also blastocyst freezing, called vitrification. And this technique on the right-hand side is very different from what we used to use and what's used in normal cell lines and that for freezing items. So there are slight differences. The vitrification process, what it does, it freezes eggs and embryos much quicker. The whole aim of vitrification is that actually it tries to minimize crystal appearance in the egg. So the most dangerous thing that can happen when you're trying to freeze something is actually if there's still water left in the cytoplasm of the egg. Unfortunately, with slow freezing, the techniques we used to use would not remove all the water from the cytoplasm of the egg. And what would happen, those would form crystals and actually break pieces within the egg or the embryo, whereas rapid cooling or rapid vitrification actually avoids that. So what you put in is basically what you get out. We expect more than 95% survival rates from what we actually vitrify in terms of eggs and also blastocysts. So this is just a quick example of vitrification and warming. So this is before freezing. If you've got an egg on the far left-hand side, we put it into a solution which is basically is designed to suck out the water and replace it with a freezing solution. Crudely, if you want, it's similar to what you used to put in your radiator so it didn't freeze during the winter. So it's the similar types of solutions that we use, not the same quality. We use a slightly higher quality though. So basically here you're equilibrating, you're trying to suck out all the water and replace it with these freezing solutions, and it's the same here. So this is a final sort of egg that actually has had all the water sucked out of it and actually has the vitrification solutions inside. The warming process, so when we thaw them, it's exactly the reverse. So basically you put it in a mix of this vitrification solution and a normal media. The water goes in, the vitrification solution goes out, and you end up with an egg that is exactly the same as when you actually froze it. We do test sometimes to make sure that everything is sort of aligned, but this is an incredibly powerful technique. To just give you an idea of how sort of it's being used now. This is a paper that we published several years ago now, and you can see here in different countries, the US being in the dark circle, Australia, New Zealand being in blue, but you can see here the actual number of patients and the number of cycles that are actually using egg freezing as a technique to actually allow them to prolong fertility or to for treatment for a medical condition is growing immensely, and this number has actually just continued right through to current day, and it's one of the largest growing areas that we have in terms of helping patients for their future fertility options. So I think we're nearly out of time, but I'm happy. I think we're very happy to take some questions if you have any.
Thank you, Dr. Sakkas and Dr. Rossi. I believe we have 2 questions right now, so we'll see if we have any more afterwards. We're going to begin answering the questions submitted during today's presentation. You can still submit a question through the questions pane in your attendee control panel if you'd like. The first question is looking at CVS and amniocentesis CVS and amniocentesis allow for diagnostic chromosome testing as opposed to screening. So for patients who have had PGTA, what prenatal screening would you recommend, if any? For example, cell-free DNA versus some form of multiple marker screening.
Yeah, I think it depends on what they're looking for. So if someone was doing PGTA, you know, that may be a candidate for cell-free DNA. My understanding of some of the cell-free DNA tests is that they only look for specific chromosomes, like the big ones like trisomy 13, 18. And often when we're doing the PGTA, they actually look at the full complement of chromosomes. So we may get more information. So you can imagine if they weren't looking at all the chromosomes on the cell-free DNA, but we did with the PGTA, you might get different results. I mean, I do think that patients, again, they would tell you, the genetic counselors will still tell you that if the patient would otherwise have undergone a CVS or an amniocentesis, that they should still do that. Especially if you've done PGTM and you're looking for a specific disease, and that may be, you know, a devastating disease to that family, then that may be something that they would look at more carefully. Would you agree, Dr. Sakkas?
Yes, I think Dr. Rossi's correct that the majority of the non-invasive prenatal testing panels do not look at all the chromosomes as we do when we're doing a PGTA for the embryo. But you know, it's a bit of an insurance policy, because any test that you do, even non-invasive PGT, non-invasive prenatal testing, even amniocentesis, they all have their risks in terms of possibly giving you the wrong answer. So I think what we're talking about is an insurance backup test, if you want, that we're doing a technique that, as you saw, it's, you know, highly technical. It's using, you know, cutting edge technologies in terms of how we screen for the embryos. And it's not a perfect technique. I don't think any of us would tell you that, you know, the results you get is exactly what's going to be. Yeah. And one of the things we have seen is that I mentioned, you know, we're not testing the whole embryo. We're only testing a small portion of it. And like any biopsy, that portion there may actually not be the complete representation of the whole embryo. So we know this for a fact. And you know, I think adding any, you know, testing going further on is only going to give the patient, you know, a bit more confidence that, you know, everything's okay. And that's what we're trying to do all along the line of the treatment.
Right.
The next question is actually directed to Denny. Have you ever done a study correlating SA, I'm guessing semen analysis, pre-IVF data versus PGD, PGTA outcomes?
So it's interesting. We actually have data on that. We're actually looking at it right now, looking at the semen analysis and looking at outcomes. Interestingly, really, semen analysis, you know, it gives us an indication that how many sperm you have and how many are moving. And basically, it can tell us if a patient should really need ICSI, or, you know, we can do conventional insemination. In terms of having any correlation to abnormal embryos, chance of live birth and things like that, we're really poor in actually looking at the sperm and having diagnostics of the sperm to give us that type of intricate information, if you want. And it's something we've been working on for many years, trying to develop different tests that gives us much more information than the standard semen analysis we do. So in terms of the type of sperm you have, really doesn't correlate that much to the expected outcomes we would have. There's only possibly if you know a patient has some sort of sex chromosome anomalies in their sperm, or higher rates of sex chromosome anomalies, there is some indication that with ICSI that there's a chance of that being passed on to their offspring. But it's about it, like fresh versus frozen sperm, testicular versus non-testicular. Once we have a sperm and we can do ICSI on it, our expected results really don't change much related to the type of sperm that we have in front of us, whether it's really good or really bad.
Thank you. The next question I think is best for Dr. Rossi. What would be the ideal maximum age for freezing eggs? Is it 34?
No, in fact, I would say 34 is kind of the age in which it's kind of the ideal age, I think. I feel like I've seen studies that have said that. We don't really have a maximum age, at least in our clinic, we don't, because you know, we believe that when patients get appropriate counseling, that they can do, you know, if it's not medically risky for the patient, and she understands that that's, you know, that she may have a 10% chance of having a child from those eggs. If she really doesn't like any other option, which would include being a parent right then, using an egg donor in the future or currently, then it would be reasonable for her to do egg freezing. I mean, I think once people get into their early mid 40s, that might be someone that we would, you know, have a more of a serious conversation and make sure they really understand their chances. But I think kind of like early mid 30s is actually a good time.
Thank you. And then this is the last question. I think it's directed to Denny. Do you do decondensation rates of semen in your testing?
So sperm DNA fragmentation, yes, we do it for select patients. So it's not a frontline test that we would do, and I actually was one of the developers of the test, so I know quite a bit about it. So, but even in, you know, I have a biased opinion of it, but I don't even see it as a frontline test you would do on a patient. But we tend to do it when we have a patient or a couple that have actually failed maybe one attempt. They have some spurious data, you know, results like poor fertilization, maybe poor embryo development. It's sort of, that's where it would be done in an in vitro fertilization setting. There are some countries, including Sweden, for example, that actually run it on patients because there actually is a good correlation of DNA fragmentation levels with outcomes of insemination. So patients that have high DNA fragmentation, if they're looking to do insemination, for example, they tend to push them more into IVF because the pregnancy rates of patients with high DNA fragmentation levels that do inseminations are actually lower. So that data is actually much more convincing than we have with correlating it to IVFs. But in terms of running it as a standard test in an in vitro fertilization setting, we tend not to. We would normally look at patients who have possibly failed 1 or 2 cycles, and we're looking for a paternal reason for that failure.
Thank you. And I did have just one more question come in. Is there a metabolic profile technique to select sperm for ICSI?
So it's interesting you mentioned that. There are some techniques that are being developed using microscopic techniques. The same technology we're using for selecting the best embryo now, for doing trials on the best embryo, we're actually looking at similar technologies for looking at sperm too. So we have data now that shows that within a sperm sample that we can see very different metabolic activities by the sperm, and hopefully we can then choose to see which of those metabolic activities may actually tie in with more success for the patient. So that is something we're actively looking at.
Thank you so much, Dr. Sakkas and Dr. Rossi. And thank you everyone